Hi there, I'm Keisha Perry. I'm a student with Northwest Florida State College, and I'm doing a presentation today on evidence-based practice, nursing research critique. So we're talking today about a CLABSI infection, or a central line associated bloodstream infection. If you're a practicing nurse, then you're very familiar with the term CLABSI. I'm sure you hear about it in services very frequently. And if you're not a practicing nurse, then you will hear about it as soon as you enter the workforce. So these infections are infections that occur in patients who have a central venous line inserted, and that's an infection that occurs within 48 hours of having the line inserted, or 48 hours from having it removed, or while they have it inserted. And it increases the morbidity and mortality rate of all the patients that have a central venous line inserted, and it affects their daily lives tremendously. So it's something that is a big core measure right now, and it's actually is affecting our pay for performance for Medicare, ACHA, and it's taken very seriously in the hospitals and acute care settings right now, specifically in the ICU, where patients frequently have the central venous lines. They may have more than one even. So we'll talk about that today. So the PICO question that I began the research critique on was, in ICU patients with a central line inserted during their current hospitalization, does the use of a chlorhexidine-containing dressing compared to a traditional occlusive dressing reduce the incidence of central line-associated bloodstream infections over a 14-day stay with an inserted central line? So I specifically narrowed down my research to the chlorhexidine-containing dressing. It's a newer technology that is out. Many facilities are utilizing the chlorhexidine cleaning agent for the insertion and for the maintenance bundle to clean the site with when you're doing site care, the weekly site care that's done on the lines, as it's so effective to kill all the bacteria that's causing the CLABSI infections. But there's not very many facilities that are utilizing that technology inside the dressing at this time, just mostly due to cost reduction. I know the facility that I work for, we currently aren't utilizing that chlorhexidine-containing dressing, but we are working on trying to get it approved according to our inpatient control nurse, because it has been proven, or shown, not proven, so effective to reduce the rate of infection. But we do utilize the chlorhexidine cleaning agent when we're doing the insertion, as well as the maintenance bundle for our central lines, and also for even our peripheral lines. When we're doing site care on them or insertion of a peripheral line, we use the chlorhexidine containing cleaner, and it is very effective. So when I started my research on the PICO question, the research that narrows down to that specific type of dressing use is not very prevalent right now. There was some, but not very many to find. Used the CN, AHL, Medline, EBSCO, and Gale for my research. And I found 11 articles for one search, 2 articles for another search, 6, and then 3. So that shows you how narrow the results got down to. The first article that I want to talk about was the closest article for my specific PICO question, and the title of the article was Reduction of Central Venous Line Associated Bloodstream Infection Rates Using Chlorhexidine-Containing Dressing. So this one specifically went to my PICO question, so that was awesome. It was written in 2013, and it was a study done in two separate ICUs. And it was over a 4-year period that they looked at the results of the interventions. And the interventions that they used were using the chlorhexidine-containing dressing specifically. So they studied patients that did not get the chlorhexidine-containing dressing versus the patients that did get the chlorhexidine-containing dressing. And the results were really good, really positive. They reduced their CLABSI rate from 5.87 per 1,000 CVL days, or per 1,000 days that a patient had central venous line, down to 1.5 per 1,000. So that was a very good, significant outcome, and that had a positive outcome that supported the PICO question. And it's a really good article. The second article that we'll talk about was called Achieving Near Zero and Zero: Who Said Interventions and Controls Don't Matter? And this was an article written by Donna Matosha, and she's a master's degree in nursing. The purpose of this process was to improve their overall process for insertion and care of the central lines to eliminate CLABSI. So that was a bold statement to make and a bold goal to try to attain. Anytime you're trying to get zero rate of infection, that's going to be hard. So, their results were actually fantastic, and they did have an ending rate at the end of their study of 0.00 infections, CLABSI infections per 1,000 days. They had to utilize collaboration with all of their nurses, all of their staff, including physicians and the techs on the floor. And they needed commitment from the staff to fully commit to the process and then improve protocols and to implement and get their results. Education for the staff, they increased their skill level with the education, and they used evidence-based practice protocols, and they utilized layered kits, which is also a newer thing that a lot of facilities are transversing to. Our facility is using these now. So they're layered from the outside of the kit to the down at the bottom of the kit, starting with what you would need first, and then moving on down for what you need for each part of the process that you're doing, and that cuts down on the process of error when people are opening up a sterile kit and they have to keep everything sterile but get everything ready at the same time. So with these new layered kits, as soon as you open up the kit, you've got hand sanitizer in there to clean your hands, and then you have the first step, which may be putting on a mask and sterile gloves to take off of the dressing with, and then you have another layer, and that layer has got more hand sanitizer on top to clean your hands, and then you open it up and it's got the inside of it is maybe for your maintenance bundle, and it's got stuff to clean and the new dressing and such. It's very effective, and they're actually really nice to use. They're very user friendly. We're all enjoying them at the hospital. So they utilized an appointed IV coordinator. So this was one person at the facility who was appointed to basically head this evidence-based practice project up, and they were at the bedside of each patient. They were part of the study every day to ensure that the nurses were being compliant with the processes and the protocols there to make sure they were following the checklists, and that worked well for this project. They were doing daily bedside audits to establish compliance with the protocols. Okay. And the third article was the impact of central line insertion bundle on central line associated bloodstream infections. So this article was written in 2014, and their purpose was to reduce the CLABSI rate by the use of an insertion bundle. So their purpose was they started at the very beginning of when you could possibly get a CLABSI infection. So the very first opportunity that you have to get this infection is when they're inserting your central venous line. And that being said, as soon as something is entering, the line is entering to your vein, entering to the bloodstream, then it can bring the bacteria right in with it from the very insertion. That's all it takes. And their project included education for their staff. They utilized a 3-tier education, so they had them actually watch 3 different educational sessions, and they encouraged all the staff on the ICU to watch the educational videos, and that would be the staff all the way up from the techs to the nurses to the doctors to the intensivists. They utilized an insertion bundle, so that was what we were talking about before in the last article, the insertion bundle that includes all the things that you would need, and they're actually utilizing as well a maximal sterile drape, so that's one of the newer processes that are out there. Instead of just draping the direct area near where you might insert the central line, they're actually doing full body drapes, so full body sterile barrier, and that's been very effective to reduce the rates of CLABSI as well. And they utilized a preferred intensivist for insertion of the central venous line. So they actually have found with previous studies and when they were doing their literature reviews, and this study also supported that as well, that when they had intensivists insert the line versus medical students who've been trained on insertion or other physicians, they had decreased CLABSI rates. And I won't attempt to explain why that they have lower rates, but they do. They utilize the need for maximal hand hygiene. So hand hygiene is where it all begins before you even touch the patient. Then you have to make sure you're doing the proper hand hygiene in order to start the process off at the best place it can be. They're utilizing the maximal sterile barrier, the intensivist, and they're avoiding the femoral vein for insertion. The femoral vein is the very last place that they want to try to put in a central venous line, and I think that's obvious why you would want to stay away from that area. It's so close to the perineal area where it could be closer to bacteria, and it's harder to get to be able to clean it. It's harder to get to maintain it. They had decreased CLABSI rates from 1.65 per 1,000 CVL days to 0.65 per 1,000 days post-intervention. So that was positive results, positive outcome. In conclusion, how does this relate to your nursing practice? I think we've discussed that throughout this presentation, but this is going to relate to your nursing practice every day. We're always trying to decrease our rate of infection. Infection control is one of the most important things that we do in nursing, and infections can be serious and deadly and certainly affect the morbidity and mortality of our patients. Infection control is top priority. We're going to decrease the ICU days per patient. Anytime you're decreasing the infection rates, you're getting them to where they're at a healthier place sooner, not letting them get as sick while they're in the hospital. That's always a negative outcome. And you can keep them out of the ICU. And I've talked also about the pay for performance. The Medicare is reducing their refunds, their funding for the hospitals and for acute care stays due to infection rates. So if a patient develops an infection, then the hospital may not receive reimbursement for that hospital stay, and that can cost tens of thousands of dollars every day. And improve your patient's outcome. That's the number one thing. We're nurses. We got into healthcare to help people and to be nurses to help our patients get better. So we want to do whatever we can do to help their outcomes be the best that they can be and help our patients stay healthy and stay out of the acute care setting whenever possible. Thank you very much. Y'all have a good day.